We're here to discuss about, well, management of viral hepatitis in this session. So whenever we talk about HBV, we talk about different pillars of care. So the first thing that we need to do is to diagnose patients. And we can do that in two ways. So we can either test, meaning that we're being reactive to something that we see. We see signs of liver disease, or we see potential risk factors for acquisition of HIV, and in that situation we test. Or we can screen, meaning that we're being proactive, we're reaching out to people and screening in order to get back results, whether they're positive or negative for viral hepatitis. And then we move into treatment. And here we have guidelines. So the topic for my talk today was about these guidelines. And we have different guidelines that are implemented in different places. So on the one hand, we have the EASL, Clinical Practice Guidelines, the European Association for the Study of Liver. Then we also have WHO, the umbrella guidelines. And then we also have local guidelines. And this is what our local guidelines look like in Romania. Most of these guidelines, they align, but there are certain differences in terms of indications, eligibility for treatment, and we're going to talk a bit about that. And then, of course, we have to monitor our patients. So in this session, we're going to be talking about patients with hepatitis B virus infection, actually. But you've seen in the session this morning that actually this is just a small fraction of all the patients who are actually living with hepatitis B virus infection, because the undiagnosed fraction is just so large. So of course there's room for more proactive measures in order to be diagnosing these patients, because there are estimates, and you've seen those in the session this morning, so from 10% to 30% of the patients have been diagnosed. All the rest have not been diagnosed yet, and they are living with hepatitis B virus infection right now. So once we diagnose the patient, we know that we have the global health sector strategy since 2016, and different countries in Europe and different countries worldwide have committed to meeting these targets. And the targets for viral hepatitis, they're quite straightforward. So 90% reduction in new infections and 65% reduction in mortality, so deaths, due to the existing cases of viral hepatitis. And of course, these targets, they were for 2030, which is quite close. So we have progress, we're measuring progress in terms of how far each country is progressing to meeting these targets. And the strategy has been revised in 2022 to offer a comprehensive approach, so integrating viral hepatitis, HIV, and STIs in order to offer a uniform, comprehensive response. So for hepatitis B, I was saying that if we want to treat a patient, we have to first find the patient, diagnose the patient. And again, looking at the guidelines, the recommendations for testing, they're a bit different in different guidelines. So if we look at the EASL guidelines, there's the recommendation to test patients who have elevated liver enzymes, who have signs of liver disease, who already have liver cancer, for example. But apart from that, there's an umbrella statement saying that because of the importance of really diagnosing patients early, because we have available treatment options that are safe, that are effective, it's becoming more and more important to move diagnosis to earlier during the course of disease. So we shouldn't wait for the signs of liver disease to be present, and we should be proactive. So the umbrella statement is that EASL advocates population-based screening beyond risk groups. So beyond those that already have signs of liver disease, beyond those that are at behavioral risk of acquiring HBV, so being more proactive. Which is in line with what the CDC in the US did in 2023 when they opened up screening, and they have, again, a statement saying that CDC recommends screening all adults aged 18 and older for HBV at least once during the lifetime. And then, of course, those that remain at risk of acquiring, be it behavioral risk, being occupational risk, those can be rescreened on a yearly basis, for example, or as often as needed. So test everyone at least once. And then what tests do we use? The recommendation from the CDC, again, is comprehensive. So they're recommending the triple panel test, meaning we test for HBs antigen to see if infection is there, but we also test simultaneously for HBs antibodies and anti-HBC, because these results will give us the opportunity to make a decision and a recommendation for the patient. If the patient tests positive, then yes, we link them to care. If the patient tests negative for antibodies and an anti-HBC, then we know we link them to prevention, we link them to vaccination because we have an effective vaccine for HBV. So my topic is about HBV, but I'm just going to bring you back for 1 second to the history of treatment for HCV, so hepatitis C virus, because nowadays we know that we have a universal recommendation to treat everyone as soon as possible after diagnosis. And this has not always been true because historically, since the introduction of direct-acting antivirals, we've had recommendations for which categories to be prioritized for earlier treatment. And it took a while until we got to the treat-all approach. And hopefully, we are going to move to a treat-all approach for hepatitis B sometime in the future. And if we look at the WHO guidelines for treatment, what these guidelines do, so they date back to March 2024. And they implemented some changes. And these changes, they relate to expanding treatment eligibility, so allowing earlier treatment for patients who have been diagnosed with HBV, expanding antiviral prophylaxis during pregnancy, and very importantly, simplifying service delivery. So making monitor available, meeting the patients where they are and meeting their needs as we see them. So pregnant women, pregnant persons should be tested every pregnancy. This is not something new, but it's there in every guideline. Every pregnancy should be tested at least once with HBs antigen. If they're positive, then the recommendation to check the viral load has been moved earlier. So in the second trimester of pregnancy, because if the viral load is high, we should start tenofovir-based prophylaxis for transmission, vertical transmission, in the second trimester. We no longer wait towards the third trimester of pregnancy. But very importantly, what's really new in this guideline is that if we don't have access to viral load, then the recommendation is to recommend prophylaxis to every pregnant female who tests positive for HBs antigen. So it has opened up the recommendation to really prevent vertical transmission. For all of the other patients, there's a recommendation to treat adults and adolescents who still have a set of criteria. So it's the same set of criteria that we know, but this time we have or between the different criteria. So they either have liver fibrosis, or they have a high viral load and high ALT, or, and again, here we have opening up for different possibilities. So patients become eligible if they have any of the items in the middle box. So if they have comorbidities, if they have co-infections, if they have immune suppression, if they have extrahepatic manifestations. So this opens up treatment to the clinical judgment. So if us as clinicians consider that this patient would benefit for treatment, the patient becomes eligible for treatment. And again, in the absence of access to HBV DNA, because we know that access to testing is different in different regions, in the absence of viral load, it's enough to just check the ALT levels, and if they're persistently high, that is, again, an indication for treatment. And this is similar to what the EASL guidelines, so there's the same algorithm stating that you should check for liver disease, you should check for fibrosis, you should check for viral load. But again, something new is that we have another umbrella statement that says that in principle, all HBs antigen positive individuals with detectable HBV DNA are candidates for antiviral therapy. So we should keep this in mind, that any patient that we diagnose with hepatitis B virus infection is a candidate for treatment, and yes, when we start the treatment is going to be our clinical decision, but we're moving towards earlier treatment, and I'm going to show you a bit about that towards the end of the presentation. So again, the EASL guidelines, they keep the recommendation for either nucleoside-nucleotide analogs, so entecavir, tenofovir with both forms, TDF and TAF, and also PEG interferon alpha. They still keep it in the guidelines, but it's for a selected subpopulation of patients who are maybe younger, they have no comorbidities, and who might be able to tolerate a finite duration of 48 weeks. But we know the side effect profile of interferon, and we know how hard it is for a patient to complete the 48 weeks due to profound neutropenia, risk of infectious diseases, thrombocytopenia, and all of the other complications. So basically, what we're doing is we're moving into nucleoside-nucleotide analog treatment, long-term treatment. So once we start a patient on a nuke, we're going to keep the patient on the nuke for the foreseeable future. And again, we have recommendations for children and adolescents as well, because we should leave no one behind. We should be offering treatment to everyone who needs treatment. And the drugs are licensed, most of them, they're licensed for use starting at 2 years old. And of course, we have different doses. Very, very importantly, once we diagnose a patient with hepatitis B, we will continue to monitor that patient. We will bring them in routinely every 6 to 12 months, and we will continue to monitor liver disease, and we will continue to screen for hepatocellular carcinoma. Because with hepatitis B virus infection, there's a risk of transforming into hepatocellular carcinoma at any point. It can happen at any time during the course of infection. The patient doesn't need to go through all stages of fibrosis, liver cirrhosis, and then develop hepatocellular carcinoma. And again, we'll talk a bit about that as well. So how do we monitor patients during treatment? Well, we have the classical parameters that we check. So we check for viral load. We want to see that viral load become undetectable. We want to see ALT levels normalizing. We also want to see fibrosis not progressing. And then if we had fibrosis when we started treatment, we want to see a slow regression of fibrosis to lower fibrosis stages. And very importantly, the EASL guidelines now recommend the routine use of the quantitative version of the HBs antigen, and we'll see why this is very important. And only where the quantitative antigen is not available, we can still revert to the qualitative one. So, treatment goals. I was saying that we want to see our patients undetectable, and you've seen in the session this morning just how important it is and how well it's going for HIV infection, where we have the cascade of care, and when we start treatment on patients on treatment as early as possible, we get them undetectable, we keep them undetectable, and we saw how important that impact is on patient outcomes. And we're trying to think in the same way for hepatitis B virus as well. And if you remember the slides from the first session, the numbers of patients who are being treated for hepatitis B were much, much lower than those for patients with HIV. So we should learn from the lessons that we have created from the HIV epidemic, and we should try to translate them to viral hepatitis, of course, where it makes sense to do so. So the goals of treatment: get the patient undetectable, keep the patient undetectable, and then continue to manage and to monitor the levels of quantitative HBs antigen, because that is the closest proxy and the most widely available proxy for what's actually happening in the liver and what's happening with the cccDNA. And of course, there are other markers, pre-genomic RNA, and other markers that are or are not implemented in different settings and have or do not have indications for routine management, but we're also trying to understand how to better include those in monitoring our patients. So we want to see our patient being undetectable, we want to see improvement in liver parameters and improvement in fibrosis. And I was saying that once we start a patient on a nuke treatment, we will keep the patient on the nuke treatment. And there are some recommendations in the guidelines saying that if you want to stop nuke treatment, you can do so, but only after consultation with someone who's really experienced in this, and if the patient can be monitored really closely. Why? Because there's a real high risk of having a flare after stopping nuke treatment, and that flare can either lead to clearance of viral infection, but that is exceedingly rare, particularly in European populations, or it can lead to severe liver outcomes. So theoretically, we can stop nukes in highly selected patient populations, those who have been undetectable for several years, who have really low quantitative HBs antigen, but we need to monitor them really closely. Why we won't stop nuke treatment is actually what's in the pipeline, and that you will see that in the presentation that follows, because much of the drugs in the pipelines, they come as add-on to nuke treatment. So theoretically, we don't stop nukes once we start them. So just a quick look towards the future. So what the future holds and what the future in hepatitis B should look like. It should look like this. Treat all. Treat pregnant, treat non-pregnant women, treat men, treat children, treat adolescents. And why are we perhaps moving towards this recommendation to treat everyone? Well, because early antiviral nuke treatment is exceedingly safe. And there are plenty of studies that are accumulating, showing us that if you start nuke treatment early, we are going to prevent integration of viral DNA. We know that this is an event that occurs during HBV infection with random integrations of viral DNA into the human cells. And these events, they're random, but they tend to accumulate. So the longer the patient is living with hepatitis B virus infection, the more number of such insertions they will accumulate. And at some point, there is the risk that this will lead to CHIP, so another kind of CHIP than the one that you heard in the session this morning, clonal hyperplasia of indeterminate potential. And these kind of cells, there's the cells that can then lead to hepatocellular carcinoma. And the mechanisms, they have been widely studied. So these viral integrations, they lead to chromosomal instability, epigenetic modifications, and mutagenesis. And these events, they accumulate over time. So the earlier we start antiviral treatment with a nuke, the more we block the integration of a viral material, and then the lower the risk of HCC progression. And again, multiple mechanisms behind early treatment slowing down or blocking the progression towards hepatocellular carcinoma. And I was saying that we're perhaps thinking about introducing early nuke treatment, and it also has to be long-term nuke treatment. Why does it have to be long-term? Well, because if we suppress the viral load in the long term, with the years of treatment that accumulate, we are going to see that the patient eventually starts to express lower levels of quantitative HBs antigen. And these lower levels of quantitative antigen are the indicator that is most closely associated with a potential for functional cure. And the next talk is on functional cure, so this is just a teaser and an introduction to the next session, because all of the different drugs in the pipeline, so small interfering RNAs, antisense oligonucleotides, and even the simple gesture of stopping nuke treatment, they have a higher chance of leading to functional cure if the patient had been virally suppressed for several years and the baseline level of quantitative HBs antigen was lower. And I was telling you that whatever is in the pipeline is currently being studied as an add-on to long-term nuke treatment. So perhaps we are looking towards a brighter future for our patients with HBV infection, in which we will move into diagnosing patients, early treatment and long-term treatment, in order to then move into the functional cure that I was saying you will hear about in the next session. So this is just a teaser where we have in the pipeline, you're going to see in the next presentation that we have drugs that want to stop viral replication and stop synthesis of HBs antigen. And of course, different classes are currently in the pipeline. And we also have immunotherapeutics that want to boost the natural response to the presence of the virus, because we know that in chronic infections, we see exhaustion of immune responses. And by boosting them and coupling them with something that keeps the virus in check, then there is the potential for functional cure. And very importantly, this was a really good talk from the EASL conference in Amsterdam this year. If you see, these are some of the studies that are currently being trialed. All of them are combination treatment. So we have combination treatment for HIV. We now have combination treatment with direct-acting antivirals for hepatitis C. We will probably have combination treatment for hepatitis B virus with blocking the different mechanisms. So having the nuke, having those that lead to lowering the viral antigen burden and also boosting the immune response. So perhaps this might be the brighter future for our patients living with HBV. And because this session was co-organized together with the ESMID study group for viral hepatitis, this is just a nice paper that reminds us that, yes, we are treating patients who have hepatitis B virus infection, but our patients also have other comorbidities. And if our patients also have MASLD, so metabolic dysfunction-associated steatotic liver disease, there's so much more that we need to understand because there's an interplay of the metabolic and the viral factors, which potentiates both hepatic steatosis, fibrosis, and inflammation. And we need to really understand what's going on with our patient as a whole in order for us to address all of these different mechanisms. And the study group for viral hepatitis is organizing different conferences, and I'm going to leave you the link to join some of them. And our next webinar is going to be about Hep Delta, because we know that this is an issue in patients living with HBV who can also be co-infected with hepatitis delta. And this is the QR code for registration to the webinar that will be organized in December together with SOLDA, so the Society for Liver Disease in Africa, in order to offer a broader perspective. And these are the links to the social media where you can find the different educational opportunities that the study group is currently providing. So just search for EHGVH on any of the social media platforms and you can find us there. And just to conclude, because the pipeline talk that is coming next is actually going to be the most exciting part of the session in terms of HBV, we need to do more. We need to do more for our patients. We need to enhance our efforts to enhance screening. We also need to enhance treatment eligibility, so earlier treatment for a wider array of patients. And we need enhanced surveillance to understand how everything that we're doing is actually impacting public health in a good way. But we also need to stand back and do less. So we need to simplify our management protocols. We have to forget all about all the complicated graphs that I showed you, checking for HBV DNA, checking for ALT, keeping to measure the ALT several times. We have to simplify things because the drugs that we now have available, they're effective and they're safe, and we can simplify the ways that we are offering access to them and delivering them. So we absolutely need to stand back and simplify the management protocols and the care pathways. Thank you.